neutral line, I can say that, or neutral. Y'all recognize those anatomy words? It's on the occipital bone here, and the spines of C7 to T12. Okay, now, on this picture, where is C7? Covered? Right? Does anybody have a question?
Why is it attached to the spine of C1
That's the question. Beautiful. That is the question. It is not. The reason for this is because two reasons. One, the spinous process of C7 is distinct. It is longer than the first 6, and I can prove it. Just bend over, I see you all doing that. That knot you feel on your neck is C7. It is known as the vertebra prominens. Recognize that word? The vertebra prominens, C7. So the spinous processes of C1 to C6 are shorter. And there is this odd ligament called a ligamentum nuchae. A thick, ligamentous, dense connective tissue band that sits on top of C1 to C6. That's what the trapezius is attached to. It's not attached directly to the bone. So this is correct. The spines of C7 all the way down to T12. We'll keep these straight now. C7 to T12. We get the rhomboids for C7 to T5. Keep track of these as we go. It also attaches to the clavicle. There is an anterior attachment of the trapezius. I keep trying to show you guys this in the lab. Most of the people that I've looked at muscles with, I show you this, right? Y'all found where the deltoid, right? Where the deltoid attaches to the clavicle and it attaches to the spine of the scapula. So does the trapezius. Not on the same spot, right? They're both attached there. You can actually see that on your cats. I think the one up front, y'all's cat, yes? Didn't y'all get, who was the one up in the front of the lab I saw? This beautiful separation between, was that y'all's cat? Yeah, that was y'all's cat. Beautiful separation between the deltoid and the traps up there on the anterior portion. So you can see it on both the spine and the clavicle. Both muscles attached on the front and the back. So clavicle, spinal scapula, and acromion, and it gets 11 and C3, C4. Explain. This one gets 11 and C2, C3. This one gets 11 and C3, C4. Yeah, these are spinal branches using cranial nerve 11 to innervate this muscle. So that's what we talked about just a moment ago. And I labeled a couple other things on here for you. We'll do that as the pictures go. Now, tear the trapezius off, and we're going to look at the levator scapula and the rhomboids, etc. But before we do that, I have to teach you a little bone anatomy. Now, this should be reviewed. Bop, 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 right through it. Yes? Okay. So this is spinal cord. I've done neck. I'm doing back. Now I'm going to work my way down the cord. I need to talk about these vertebral bones. I need to be able to say these things. You know them already. A few side notes as we go through this. Okay. So first of all, the vertebra, there's 26 of them, right? 7 cervical, 12 thoracic, 5 lumbar, a sacrum and a coccyx. Now, as you work your way down, you can see in a normal spinal cord, there are curves. So there's a ventral curve in the cervical region, a dorsal curve in the thoracic region, a ventral curve in the lumbar region, and a dorsal curve in the sacrum and coccyx. These are normal curves. Normal spinal cords are curved. However, there are conditions where this gets out of whack, right? All of us were tested when we were kids for scoliosis, which is an abnormal lateral curve. There's also a condition where there's a dorsally exaggerated thoracic curve. You might know what that's called. No, that's the ventrally exaggerated cervical, but I'm going to say that one next.
Kyphosis?
Yeah, so kyphosis is this dorsally exaggerated curve, and then lordosis is this curve. It is a ventral exaggerated lumbar curve and cervical. Normally you see it more pronounced in the lumbar area. Okay, so there are normal curves and there are clinical conditions that are not normal. So scoliosis and kyphosis and lordosis are all clinical descriptions of abnormal curves. Now, the first cervical bone is called the atlas and the second one is called the axis. These are unusual bones, right? The atlas does not have a body. What is there instead of the body on the atlas? If y'all help me with this, we'll go through it real quick. What's there instead of the body?
The dens.
Mm-hmm.
The dens.
Okay, right, yeah, so the dens of C2 is there. Exactly. So there's a fovea dentis there on the atlas where the dens articulates. How do you distinguish the superior articulating facet from the inferior articulating facet of the atlas? Okay, start with this. The superior articulating facet of the atlas articulates with what bone? Occipital condyle. Okay. How do you distinguish the superior from the inferior facets on this bone? That's exactly right. The superior articulating facet almost looks like two facets. It's a very broad, wide facet on the superior side. The inferior side articulates with C2. So it's much larger. Now this shows you that the spinous processes of many of these cervical bones have rabbit ears on them. And the ones in the lab, that didn't really show up, did it? Y'all see any bifid processes? Yeah. So this is something that you typically would expect to see. When you get down to C7, that normally disappears. So that's not a big deal to me. But there's another very important piece of anatomy here that distinguishes the cervical from thoracic bones. The transverse processes. The transverse processes. Now, have we already seen a muscle attached to the transverse processes of the cervical bones? The scalenes, okay? Now here's another observation about the transverse processes. They have holes in them. And they are really, really important. Really, really important. Because these are the holes through which the vertebral arteries pass on their way to the brain. And I have just completed the way your brain gets blood. Right? Because off of the carotid sinus, which is located 2 fingers below the angle of the ramus of the mandible, comes the internal carotid artery, which passes through a hole in the temporal bone called the carotid canal. It supplies an anastomosing circle on the bottom of the brain called the circle of Willis. Those are 2 of the vessels that come to the anterior portion of that circle. The ones that go to the posterior portion of that circle come off blood vessels that we'll learn later and become vertebral arteries. Those vertebral arteries pass through the transverse foramina of the cervical bones all the way up to C1, where they come off the transverse foramina and turn and go into the brain. They turn and go into the brain along with the spinal cord through the foramen magnum. And they supply blood to the back of that circle. How many blood vessels supply blood to your brain? 4. 2 internal carotids through the carotid canal of the temporal bone, 2 vertebrals that pass through the transverse foramina of the cervical bone and enter the skull through the foramen magnum. All right? So that's C1, C2, atlas axis, and the telltale signs of the cervical bones, which are the transverse foramina. The thoracic bones, as you work your way down the cord, have angled spinous processes. This is one of the defining characteristics of the thoracic bones. They have angled spinous processes. They angle which way? In caudal, good. Inferior or caudal, exactly. So the spinous processes of the thoracic bones have inferior projections. These bones also have facets for Ribs, the thoracic bones, have a facet on their transverse process for what part of the rib?
Cost.
I'm going to say it again. The thoracic bones have a facet or a facet that articulates with, on the transverse process, that articulates with what part of the rib? The thoracic bones on the transverse processes have a facet that articulates with what part of the rib?
The rib.
The tubercle. Good. The fovea are facet for the tubercle of the rib. And the bodies of the bodies of the thoracic bones have facets on them, smooth surfaces that articulate with what part of the ribs? The heads. So the thoracic bones have downward angled spinous processes, and they have facets for the articulation of ribs. Heads on the bodies, tubercles on transverse processes. That one was hard. I didn't ask, it's not your fault. Okay, so you also notice that just like their cousins in the cervical region, they have superior and inferior articulating facets or processes that articulate with the bone above and the bone below. Now, the thing to notice here, the really important feature of this particular articulation for these bones is that they articulate in a pure superior to inferior fashion. The superior facet faces superior. Actually faces dorsal, but I want you to think superior, inferior here. It faces superior, and the inferior facets of these face inferior. So, if were it not for a lot of other connections, these things could slide medial lateral. Their anatomy, their simple anatomy, doesn't explain why they can't do this. It looks like they could slide medial and lateral. There's a major difference between these and the next group. These are lumbar bones, where those facets of the lumbar bones are angled, instead of like this, they're turned like this. So the articulations of the lumbar bones face medial lateral. So moving the bone medial lateral in the lumbar region is not going to happen based on the bone attachment. So there are medial lateral articulations for the facets, the superior and inferior articulating facets of the lumbar bones. Now, also notice the spinous processes are now sticking straight out. And the last thing about these lumbar bones is they are much larger. And you think of some other physical phenomenon that would explain why the bodies and spinous processes and transverse processes, for that matter, of these lumbar bones are so much larger than their cousins in the thoracic region. Yeah, these are the weight-bearing bones of the vertebral column. Good. All right. Now the sacrum and coccyx have holes in them. There's a hole here, labeled here the superior portion of the sacral canal, through which things should be passing in the nervous system. Is the spinal cord here? No. Okay, so what's going to be passing out of these anterior and posterior sacral foramina, do you imagine?
The plexus.
Good, yeah, so y'all are thinking in the right direction here. These are going to be the nerves that will be forming the lumbar and sacral plexus. Now when we learn this, like when I form the femoral nerve, I'm going to come off of L2, L3, and L4. When I come off of the sacral portion, I'm going to form the sciatic nerve with sacral divisions. And I think most people at this point think to themselves, when they're learning these spinal cord divisions that feed these nerves, they imagine a spinal cord here. But really, where is that information? If you want to say the spinal cord, anatomically, where is the origination point for the sacral nerves? In the lumbar region, right? Okay. All right, so these are fused bones here, the sacrum and the coccyx are fused bones in the adult. There are multiple bones, but there's normally 4 or 5 sacral bones that are fused and 3 or 4 coccyx bones that are fused together. Now, the sacrum, when we finally get down to the hips, I'll point this out again. The sacrum has this auricular surface on it that articulates with the ilium of the hip and helps me, it will help me to define for you. That articulation will help me define the true and false pelvis for you later. Okay, so that gets the vertebral column. Let's do the ribs, and then I can start talking about all the muscles attached on these things. We did the sternum already, the maneuvering of the sternum in the xiphoid process. You know that there are 12 pairs of ribs. The first 7 are called true, and the last 5 are called false. Why is that?
Is it not directly?
Say again?
False ones don't directly attach to the stone.
Okay, good. Do they attach at all?
Yes.
Okay, good. So the first 7 ribs attach to the sternum directly. The 8th, 9th, and 10th rib attach to the sternum indirectly by way of the 7th costal cartilage. And the last 2 are floaters, 11 and 12. So true and false ribs. Okay. Here's the clavicle, and then I'm done with the bones, I believe. We go back, yeah, this. I'm not going to finish this today. Okay. So this is a shot of the clavicle, the acromial end and the sternal end. Notice the conoid and costal tubercles or tuberosities. Here, the conoid and the costal both will be attachment points that I'll mention to you for ligaments. And how do you guys determine, when you look at a clavicle, how did you determine which one goes on the right and left of the body?
By the side of the tubercles.
Okay, different ways. I got a flipper, and what'd you get?
The side of the tubercles are.
Okay,
if
what
it
is
was
it?
posterior or anterior.
Oh, okay. I don't think about it like a hook. I think about it, and you can hook people this way and hook people that way. And so the hook on the bone here is the portion that faces anterior. And that's the way I always orient the clavicle when I pick it up. Hook it with the acromial end. Now, interesting, this bone is the only thing that keeps your shoulder lateral. Process that for a second. The only thing that keeps your shoulder lateral. A severed clavicle would make it possible for you to take your shoulder and pull it over here.
That's good.
Yeah. So this is the shoulder. And man, is it tough. Every year when we're in New Orleans, I have the kids try to cut the clavicle to prove this. So the Gross Lab has these big, huge bone cutters in there. So I hand it to one of the tough guys, and say, all right, cut the clavicle. No way you get through this. It's very difficult to break this bone in two. You can fracture it with a severe, with some severe, blunt force. But to cut it in half, to sever it in half is really difficult. You have to take, in order for them to cut it, I give them a chisel and a hammer and let them pound away at it just to get them some, physical experience with the body cutting the clavicle. All right, here's the last one for today. And then we'll pick back up with the cervical plexus again. We'll start on Wednesday. This is the scapula, and oh my word, the things that we will do here, the journeys that we will take across this bone. So from a posterior view here, there's an infraspinous and a supraspinous fossa and a spine. So we'll put a muscle here. You start learning them already. Start learning them. A muscle in the infraspinous fossa, I will call it the infraspinatus. A muscle in the supraspinous fossa, I will call it supraspinatus. Y'all did this in lab Thursday, yeah? So we're going to find all kinds of things attached to the spine, including the trapezius and the deltoid. The acromion is the point that articulates with the clavicle, the point of the shoulder here. The coracoid process over on this side, this is the anterior side, is an attachment point for the coracoacromial ligament the coracohumeral ligaments, attachment for the coracobrachialis, attachment for the short head of the bicep, attachment for the pectoralis minor, all kinds of things on this guy right here. This will be a major question on your lab exam. I will have a piece of tape on that thing, and I will say, name 5 things that are attached here. So that always shows up. Y'all heard me just spout them off, and we'll do them as we go. This is the subscapular fossa. There's a muscle there. What would you like to call it? The subscapularis. So those 3, infraspinatus, supraspinatus, and subscapularis, are 3 of the 4 muscles of what we know affectionately as the rotator cuff. Yeah, all attached to the greater tubercle humerus. And then the glenoid cavity, very odd piece of anatomy here. It's a pretty flat surface. Did y'all notice that? Yeah, and the head of the humerus is this big old round piece. This is not a stable joint. So as I teach you the joints here over the course of the next couple of class periods, when we finally get to the shoulder, I'm going to make that a big deal. You're going to learn from me the head of the humerus attaching in the glenoid cavity as a very unstable scenario. Your job will be to tell me what are the things that actually keep this thing in place. And so we'll learn all kinds of different little nuances of anatomy that explain how it's possible to keep the head of the humerus in there. It will come out, and that's not good, but it doesn't come out as easy as it looks. Okay, and then the last couple here, the infraglenoid tubercle, which is attachment for the, has anybody got to these yet in the arm? The infraglenoid tubercle. So there's 3 heads of a muscle in the back of your arm: a lateral, a long, and a medial. Yes? The tricep, yeah. So this is the long head, the tricep attaches here. The lateral and medial heads both attach to the humerus itself and to the olecranon. And so I'm just tipping you off. These are coming. This is the lateral border. This is the medial border. Next class period, we're going to put the rhomboids right here, and on C7 and T5 on this medial border. We're going to put the levator scapula right there. We're going to put the teres minor right here and put it on the lesser tubercle. That's a rotator cuff muscle. And then we're going to put the teres major right there, and we're going to run it around to the front of the humerus. Why is the minor a rotator cuff stability muscle and the major not? It has to do with where it's attached, close to the intertubercular groove, along with all kinds of other things, including latissimus dorsi, the pectoralis major, all attached near to each other with the minor. So I'm blathering, I know, but oh my word, the places we're going to go with this bone over the next couple class periods. All right, when we start class next time, we're going to do this again. I'm going to do cervical plexus with you again. We're going to bop through it, review together, and then to the trapezius, review, and then it is upon us. The brachial plexus is next on Wednesday. This is a tip for class, but it is also a way to remember roots, trunks, divisions, chords. When I say root here, you think ventral root? Well, what are we going to learn? This is a mess. A root for the brachial plexus means the ventral rami. That's right. Okay, so that will be on Wednesday.